Sophia Simon is a 75-year-old woman with a long-standing history of hypertension and type 2 diabetes mellitus. She was diagnosed with heart failure 18 months ago, and she has been followed by a cardiologist. Her current medications include metoprolol 100 milligrams daily, enalapril 10 milligrams daily, and metformin 1,000 milligrams daily. She's a non-smoker, and she has no history of coronary disease or peripheral arterial disease. Her baseline left ventricular ejection fraction is 35%. She just presented to the emergency room a few minutes ago, complaining of shortness of breath.
Hello, Mrs. Simon. I'm Dr. Phillips. I see you're having a bit of trouble with your breathing. How long has it been going on?
Past couple of days.
Oh, yeah. Did it come on suddenly, or has it been going gradually getting worse?
It's getting worse.
Yeah, I see. I understand you have a history of heart failure. Have you noticed any swelling of your legs?
Yes. Try putting them up.
Yes.
Doesn't work.
Yes, I can see. When was the last time you saw a cardiologist?
Made an appointment.
Yes.
Things got worse. I couldn't wait.
I'm glad you didn't try to wait until your appointment. What was her oxygen level when she came in?
86% on room air.
Yes.
Respiration rate was 30.
Okay.
Initial BP was 160 over 100. Pulse was irregularly irregular at a rate of 127. And temp was 37.2.
I see. Anyway, your nurse and I will keep a close eye on you. I need to step out just briefly to arrange for a chest X-ray and lab test. But I'll be back after and we'll have a talk a bit more about everything. But let me take a listen of your lungs and heart, please, first. So. Okay, move forward a bit. Thank you. Hello, Mrs. Simon. Dr. Carr. Yes, I am in the end on my shift and I wanted to check on you before I leave. It's been about 2 hours since we gave you the IV medicine in the ER. I see that your oxygen saturation is now 92%. It looked like the CPAP mask was very helpful. How are you feeling now?
Oh, a bit better.
Good.
It's getting easier to breathe now, and my heart isn't beating quite as fast. I feel like I can actually talk now.
Good. It sounds like the furosemide and the vasodilatator we gave you into the ER helps you to get rid of quite a bit of fluid. Your heart is also now in a regular rhythm. I was quite concerned about you when Dr. Kerr and I discussed your situation. We determined that it would be best to transfer you to the cardiac unit.
Yes, we want to watch you closely. It is important to treat this acute heart failure without delay. When did you realise you needed to go to the ER rather than come to my office?
Well, I usually go to my daughter's house after supper. But when I tried to walk the 2 blocks to her house, I got concerned. Well, I thought I could make it until morning. But when I tried to lie down to go to sleep, I couldn't breathe. I got worried.
We need to figure out why this happened so that we can adjust your medications, your treatments to help keep you out of the hospital. You'll probably be here for just a day or two until we completed our testing, and then we'll send you home.
Okay.
I'm glad to see things are improving already. Hopefully you won't have to see me in the ER again after you discharge. Madame, take care.
Oh, thank you.
You're welcome.
Acute heart failure is a serious condition and it should be treated aggressively in a time-sensitive manner. Patients with acute heart failure may present with peripheral edema, fatigue, decreased exercise tolerance, shortness of breath, orthopnea, and paroxysmal nocturnal dyspnea. Symptoms can develop rather rapidly, and the patient's condition can deteriorate quickly. The treatment algorithm for acute heart failure involves immediate assessment of the patient upon presentation and requires frequent reassessment over the course of 2 hours. The first step is to determine the severity of the episode. If the patient is at high risk for acute coronary syndrome, they should be sent to the cath lab immediately. The patient's respiratory rate, lung sounds, oxygen saturation levels, and blood pressure should all be monitored. If the patient has an oxygen saturation less than 90%, exhibits signs of hyperperfusion with a systolic blood pressure less than 90 mm of mercury, or other hemodynamic instability, they may need to be transferred to an intensive care unit or cardiac care unit. Additional ICU admission criteria include heart rate below 40 or above 130, or presence of a severe arrhythmia. Diagnostic tests should be performed to help guide further treatment, but treatment with IV diuretics or vasodilators should be initiated immediately while diagnostic testing is in process. Do not wait for test results to come back before starting therapy. An EKG can help rule out myocardial infarction, and a chest X-ray will help to rule out other potential causes of shortness of breath. An echocardiogram should be done at some point, but does not have to be done immediately. If available, bedside ultrasonography may help to determine the severity of pulmonary edema. Initial laboratory tests should include a plasma natriuretic peptide level, troponin, electrolytes, serum glucose, BUN, creatinine, a complete blood count, and if you suspect a pulmonary embolism, a D-dimer level should also be done. Arterial blood gas levels are not routinely drawn, but they can be helpful. Oxygen should be administered if the patient's saturation level is below 90. If the patient is in respiratory distress, start non-invasive ventilation, such as pressure support PEEP or CPAP, to reduce the potential need for intubation. All patients should be reassessed after 2 hours. If they have adequate urine output, oxygen saturation greater than 95%, a resting heart rate less than 100, no postural hypotension, and report improvement of their symptoms, they may be able to be discharged home from the emergency department as long as there is a close outpatient follow-up and the cause of the acute episode can be determined. By contrast, if the patient remains unstable based on previously discussed criteria, they should be admitted to an intensive or cardiac care unit for close monitoring. Otherwise, patients can be admitted to a regular hospital ward and monitored there for 24 to 48 hours before discharge.
How are you feeling today, Mrs. Simon? Are you continuing to improve?
Yes, I definitely feel better than I did yesterday.
Good. You know, when someone comes in with an episode of worsening heart failure, like you did, we want to figure out why it happened so that we can adjust your medicines and treatment appropriately. I was reviewing your chart and the results of your tests, and it looks like when you came into the ER, you were in an abnormal heart rhythm. It's called atrial fibrillation.
Oh, well, I know that my heart was beating terribly fast. Well, I just thought it was because I was anxious.
Well, certainly anxiety can sometimes make your heart beat fast, but in this case the abnormal heart rhythm was the cause when you came into the ER last night. Did you ever notice your heart beating fast before this?
No, I don't recall it beating as fast as this.
Okay, So, as far as we know, this is the first time you have ever been in atrial fibrillation. Let me explain. When your heart goes into an abnormal rhythm, like that, it doesn't pump your blood efficiently, and is the likely reason why you notice more problems breathing and swelling in your ankles.
Yes, the swelling seems down a bit today. Will my heart stay in that rhythm?
Your heart is now back in a normal rhythm, but there is a possibility that it may go into that abnormal rhythm in the future. I think we can control your heart rate with a metoprolol, though I'm going to increase the dose a bit. My goal is to keep your heart rate between 60 and 100.
Is the heart rate the only reason that I have problems breathing?
Well, yes, this episode is most likely due to that. We want to do another echo to look at your heart, and we'll be monitoring your weight and your lab tests to make sure we get your symptoms under control before we send you home. I think it may be a day or two before you go home, but I anticipate we will transfer you out of this unit and into a regular hospital room within the next 24 hours, as long as things remain stable.
Okay, good.
The most common causes of acute heart failure are hypertension, acute coronary syndrome, arrhythmias, and infection. Non-compliance with treatment regimen should also be considered, and it is important to review whether the patient has been taking their medication regularly. In this case, the patient presented with atrial fibrillation, and a thoracic ultrasound needs to be done to rule out thrombus. This patient converted to regular rhythm without any specific intervention. For some patients, cardioversion is necessary. Amiodarone can be used short-term in patients who need cardioversion to reduce the likelihood of recurrent atrial fibrillation. The goal is to maintain the patient's resting ventricular rate between 60 and 100 beats per minute. If a beta blocker alone is not effective at controlling the patient's rate, digoxin may be added. Patients with atrial fibrillation should be put on an anticoagulant, preferably a non-vitamin K antagonist anticoagulant based on stroke risk assessment. Despite the fact she's now in a sinus rhythm, her Schatz-Vasc score is 5. She receives 1 point for congestive heart failure, 1 point for hypertension, 2 points for age 75 or greater, and 1 point for being female. Therefore, anticoagulant is recommended. While the patient is in the hospital, her weight should be checked daily and her fluid input and output monitored. Electrolytes and renal function testing should be measured daily, and the patient should be euvolemic with stable renal function for 24 hours prior to discharge. It is helpful to also check the level of natriuretic peptides prior to discharge. The patient's current medications should be up-titrated to optimal doses while they are in the hospital, and the patient should receive instructions about how to manage their heart failure before they go home. Arrangements for follow-up with a disease management team should be made prior to discharge. The multidisciplinary team should include the patient's cardiologist and primary care physician, as well as other staff who may be involved in the patient's care, such as physiotherapists, dietitians, pharmacists, and social workers.
So, Mrs. Simon, how are you feeling today? Has your breathing worsened, or have you noticed any increased swelling in your ankles?
No, I feel okay, but I'm not quite back to where I was. My breathing is certainly easier than when I first came in, and I'm able to walk around without feeling short of breath. I noticed today that when I took a shower that I didn't feel quite as tired.
That's great. I think we can discharge you today. I want to follow up with you closely though. We have to keep a close eye on you over the next month or two so that we can adjust your medications promptly if you don't improve. I want you to be able to stay out of the hospital.
I certainly want that too.
You should continue taking the medicines you were taking prior to being admitted, but at the dose we had you on here in the hospital. You will also be on a couple of new medications that we added since you were admitted. One is a blood thinner that we started due to the abnormal heart rhythm. The other is spironolactone, kind of water pill that helps get rid of excess fluid. In addition, the nurse and discharge planner have enrolled you in a cardiac rehab program.
When do I need to follow up with you?
Oh, well, I'd like you to follow up with your primary care provider next week and then come and see me again the week after. We'll see how you're doing then.
Okay, thank you.
So, Mrs. Simon, how have you been doing over the past couple of weeks? Does it feel like your breathing has continued to improve?
I certainly feel better than I did when I went to the hospital, though I still don't feel quite back to my normal self. Well, I can do more around the house though. I don't get tired as quickly.
Have you had any more swelling or does that seem to be resolving?
Oh, that's much better. I have some swelling in my legs by the end of the day, but it's gone when I get up in the morning.
Good. I want you to keep an eye on that. If you start noticing more swelling, or if you have swelling when you first get up in the morning, you should call your nurse. I think you have instructions too on when you should take an extra pill.
Yes, the nurse did give me some instructions when I left the hospital, and my primary care doctor has reviewed that with me also last week.
Great. Have you started the cardiac rehab program yet?
Yes, I had my first visit last week and I go again tomorrow.
Good. I anticipate that you will continue to improve over the course of the next few weeks, but I want to see you again in 2 weeks. We may need to bump up the dose of your spironolactone, depending on how you feel. If we feel we still can't get things under control that way, then we may need to consider adding another medication. Actually, it's a combination of 2 medicines, sacubitril and valsartan. That would take the place of enalapril. I will order another echo to be done before I see you again, since that will help us determine whether we need to adjust your medications.
Okay, I'm glad there are some other options. Thank you.
Absolutely, well done.
It is very important to keep close follow-up on patients once they are discharged from the hospital. 30% of patients admitted to the hospital for acute heart failure end up being readmitted within the next 60 days. We need to make sure that their therapy is optimized before they leave the hospital and then closely follow them as an outpatient. Some patients will still end up being readmitted despite optimization of therapy. It is important to emphasize to the patient the importance of regular follow-up to reduce their likelihood of being readmitted. If in 2 to 4 weeks the patient's dyspnea has not improved, you may need to consider adding a new class of medication which combines a neprilysin inhibitor with an ARB. It is called sacubitril valsartan. The patient's ACE inhibitor must be discontinued prior to the initiation of that new medication. With the recent 2016 update of the European Society of Cardiology guidelines for management of heart failure, sacubitril valsartan has a class 1B indication in symptomatic NYHA class 2 to 4 heart failure with reduced ejection fraction as a replacement for an ACE inhibitor to further reduce the risk for heart failure, hospitalization, and death in ambulatory patients who remain symptomatic. despite optimal treatment with an ACE inhibitor, a beta blocker, and an MRA. This recommendation was based on results of the Paradigm heart failure trial. In summary, it's critical to treat acute heart failure immediately and aggressively. There should be no delay due to diagnostic testing. The patients should be routinely reassessed for hemodynamic stability and triaged according to the severity of their symptoms. They should be admitted to determine the cause of their acute episode and to optimize their medication regimen. Prior to discharge, they should be hemodynamically stable and given appropriate education in how to manage their disease. They should follow up with a primary care physician within 1 week of discharge and see their cardiologist within 2 weeks of discharge. Close follow-up is critical to reduce the likelihood of readmission. A multidisciplinary team approach is best in order to coordinate care with psychosocial support and ongoing patient education.